Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking about innovations in primary care, independent and rural primary care practices. This panel discussion was recorded live on May 2nd at the event Primary Care 25. Let's get started.
To get started, Carrie, can you provide an overview of rural primary care in the U.S.? What are we seeing as far as the challenges for both the workforce and the populations in the rural areas?
Well, you all know that primary care, along with public health and emergency services, are really the essential backbone of how we provide care in our rural communities. And, when you think about it, primary care really is the first point of entry into the health system, which is particularly important for rural residents that oftentimes have limited access. So as we think about rural parts of the country, primary quick care and workforce shortages are not a new thing. It is, I think, an issue folks have been struggling with for decades and has been a source of innovation in many parts of the country, but also has been a persistent challenge and remains a key challenge for today. And so a couple of just statistics to throw at you to help frame this. So 70% of the health professional shortage areas in this country are located in rural areas. That is a disproportionate number, just as a heads up. And while we have about 20% of our population living in rural areas, we only have about 10% of our physician workforce practicing there. And we continue to see closures of independent primary care practices or consolidations of those practices, which have impacts on individuals' access to care. So when you think about some of those challenges and disparities, it really aligns with what we see in our rural areas in terms of growing medical deserts and challenges of accessing a whole range of healthcare services. And that maldistribution really is reflected in kind of not only the wait times and kind of services provided in communities, but also very much in the rural health outcomes and life expectancies that we see, which are disproportionately worse in rural communities than our urban. So a couple of just thoughts on challenges or why some of these things are persistent or exist, and then I will turn it over to others. But when you think about how we get our workforce into rural areas, training is such a huge component of it, and I know we'll talk a lot about that today. But despite kind of knowing that that is a solution that works, only 2% of our Medicare-funded residency training occurs in rural areas. Again, we have 20% of the population living there. So we definitely, that's an area we need to look at. We also have seen increased levels of burnout that have really caused many health professionals to decrease their work hours, leave their practice, choose to practice in less challenging settings in some cases, further straining the rural workforce. And last but not least, we're definitely seeing the number of rural physicians that are age 50, let's say 50% too. That's a nice way to think of the age 50 or older. We've got about half of our rural physicians in that bucket, which really highlights, we've got an issue now, but it's definitely a growing issue as well.
That really sets the stage. And the part of the issue is a lot of times they have less access to resources. Like many people will have a family farm that they can't sell, but it makes them ineligible for Medicaid or for other benefits that they might have. So it can make a huge difference. And Sonya, what are your thoughts? What do you agree with, and what do you have to add to this?
I think I agree with everything that was said, and what I will do is add to that. I have to say that my voice is kind of channeling a couple of partner health centers in Maryland on the Eastern Shore and a health center in the eastern part of North Carolina. But looking from that lens, which is really the ground level, the things that kind of churn underneath those big statistics are things like increased disparities, having the opportunity to generate additional income and to demonstrate your great work through value-based metrics that then have you having to outdo yourself every year, coming within the acceptable ranges, but then you're not up against the range anymore, you're up against you. And when you're having to outdo yourself over and over, it's like that perpetual last 5 or 3 pounds that just won't go off the body. And I would also say the things that make practice harder: no broadband bus services that allows people to actually get to their appointments with transportation, no affordable housing for staff that want to move into rural areas and to live, or no available housing. And so all those things are what's underneath the statistics that Carrie is giving.
And I know by training you're a behavioralist. What's behavioral health care like in the rural areas?
The picture gets even darker. So I'm a clinical psychologist, and in terms of that workforce, the ability to meet the language needs of the folks in the rural communities, which are more and more occupied by folks who are not necessarily English as their first language speakers. There is all the high demand and the high salaries that can't be met in the rural environments. And there is, as we have talked about, as the workforce ages and the new early career professionals are going in, it's very difficult to find the fullness of life that you're looking for in those rural environments, which make those professionals go to larger markets.
Tim?
A lot of waterfront to cover. Yeah, where would you like to go? So, I mean, from my perspective, that totally agree. Lots of problems that are very well documented by NRHA and in a number of other research publications. From my perspective, what you really see in rural areas, small towns, that's different from urban, larger clusters is, it's a very cliched. Healthcare is super local, hyper local. It's especially local in rural areas, and by which I mean the spread out population, the different types of workforces available manifest. You're sort of trying to build a business and bring, in my case, bring access to seniors, and on the margin, you're going to be heavily influenced by, well, is the nearest hospital that you can recruit nurses, is it 30 minutes away, or is it like 90 minutes away, right? And so those pieces end up making it a little bit more complicated to figure out not just the markets you're in now, but your next 5 markets, and it makes it more complicated to bring access consistently in the same way across states, and that's compounded by different policies for supporting workforce access. We make good use of things like National Health Service Corps, other incentives to bring physicians to rural areas, but some states will have strong incentives for in reasonable rates in Medicaid managed care. Other states, it's a more mixed bag. You really have to get more creative to put together and run a clinic successfully in a rural market.
And Jim?
I find it's hard to follow up these 3. Those were great comments, right? And I just have to say thanks to Sean and Bethany for allowing me to be here to speak on such an important topic. Like you, Dan, I've been a primary care doc my entire career from a small town. Very dear subject. Dr. Flanagan, the comment about care should be local, right? And for Main Street, we're serving seniors, and having access to good whole person primary care and the resources they need is so challenging in rural America. Primary care is challenged as a specialty as a rule. It's what we've been speaking about today. There are changes that need to happen to remedy that. I would say the theme of today is see the possibilities. Well, the possibilities for rural primary care are honestly, there are great possibilities on the horizon. The innovations in quality and value-based care and value-based renovation give me great hope. I joined Main Street because I'd done primary care for 20 years in a traditional practice. I struggled, just like we've talked about primary care being hard today. We were talking about average family practice panel. The doctor was speaking about earlier today. Mine was 3,800 patients when I left practice to lead value-based relationships, and I struggled. What I've been so happy about is Main Street bringing health navigators to small towns across the nation, embedded into practices to help seniors find those resources that they don't know about. They don't know those extra benefits are out there. They don't know who to call. There's no one transportation number in some of our small towns. It may be run by the local church. So helping seniors, helping take some of the burden off primary care doctors to let them focus on clinical practice. Carrie, thank you for sharing some statistics a second ago. 3,300 plus independent practices closed between 2019 and 2024 in rural America. That's a lot. That's a lot of practices closed in our small towns. You know, the payment challenges. 1 in 5 physicians considering leaving practice in the next 2 years, an aging workforce. No, we're going to talk about how do we get that next generation, but you know, I feel like the underlying theme is how do we get primary care and, you know, the residents of rural America, how do we get them more help?
And Carrie, so what's your interest in why are you so interested in rural health care?
Like individually as a person? Oh, that's a nice question. Well, I am originally from Montana. I'm actually the fifth generation Montanan, believe it or not. And so, you know, it's like many here on the stage who've practiced in the setting, it's home, right? And it's, you know, I think a really important part as we think about how we deliver care in this country, you know, geography is something that folks don't always think about, but makes a huge difference in people's access. So that's my driver.
And Sonya, how about you? Because you've done most of your work in the city, but now you're looking into the rural areas. So what's driving you that direction?
Yeah, I too am a small town girl. I'm from a small town called Chapel Hill, North Carolina, where you can walk from one side of the town to the next. It's really about access. It's making sure that there are resources available in these areas where so many things are leaving. The health center that I work closest with is Bertie County Rural Health Association, which is in a very small Windsor, North Carolina, in eastern North Carolina, not far from ECU. They still have one Subway as their restaurant, and they have more people dying every year than they have being born. And so there has to be that local fire, that wanting to maintain relationships, values. If you go to Chapel Hill, North Carolina, there's a community health center called Piedmont Health Services. I was a patient of Piedmont Health Services from the moment I was released from the NICU, and all of my care has been at federally qualified health centers. They are so proud of me. You could walk in there. At one point, they had a photo, you know, in the health center, and so it's that ability to change the trajectory of lives and know the change you made because you can actually follow that child for their lifetime. It's having continuity of care that comes from someone having treated your mother and your aunt and knowing the things that run in your family so you don't have to. Those things are critically important. Good medicine includes the independent knowledge and empowerment that comes from a patient matched with the academic training that folks get from medicine, bringing those two lenses together and the synergy from both knowledge groups coming together. That's how you change health outcomes. And so making sure that that's still possible. In those little small towns, it's not just having the medical facilities that are there and serving them and being available, but having them run by people who are from there and understand them and want to raise the livelihoods of the people who are there, use health as an economic generator, and not just be there to transact a business.
So how are you innovating and investing in this work with your group?
Many different ways. I think the first way is by strategic partnerships and recognizing that those partnerships have to extend beyond those rural borders. So in Maryland, for example, 2 of the health centers on the Eastern Shore, Chesapeake Health Services and Chop Tank Community Health Systems, they are partnered with my health center in a more rural, in a more urban area, and 4 other health centers on our own health plan, our own Medicaid managed care plan, so that we have half ownership and Johns Hopkins has the other half, which gives us access to that broader array of resources, but coming together so that we can begin to design and control our fates and the lives of our participants.
On to Tim, and then this having control of the health plan, you know, would like to know what your interest in rural care is, but then how you're investing in the rural care.
My journey was more born out of frustration, I would say, than anything quite so inspirational as that. But I would say I had the pleasure of working with hundreds of health systems, rural health clinics, critical access hospitals, independent practice physicians in rural medicine in prior lives, both in policy, but then especially when I worked at Caravan Health and Signify, bringing value-based enablement solutions, bringing technology, wraparound services. And it was so hard to get progress, right? And it's working with extremely well-meaning clients, people who want to do the right thing. The payment systems are telling them to do something else or something that's like sideways to the right thing. And so it's like the rural health clinics where like, okay, you've got the patient in front of you. Now's the chance to do comprehensive health risk assessment. Now's the chance to do everything that, all the things that the patient's behind on. It's like, well, I'm going to get paid another few $100s if they come back next week though. And it's like, yes, that is what the payment system says to do, but 50% of them won't come back next week. And so like that's just reality right now in the sort of fee-for-service, core fee-for-service Medicare. And so coming back, having another chance to regroup, seeing what has been done in these advanced primary care models. We were founded by Oak Street and a number of other incubators. Saw what Oak Street did, what Chen and Iora and another of others have done. This model, it's just like first order providing access in these towns to extremely high quality, high touch, tech-enabled primary care produces such incredible improvements in patient experience and quality and avoidance of hospitalizations. Chance to build something brand new from scratch where you can avoid and make choices about all of those decisions on the margin about you don't have to bring the patient back, you can have a longer visit. We've got to build it around a different type of economic model, but it can really work wonders, right? As I know you know personally. So that was the real excitement here, and working in a space where, hasn't really been figured out. The big operators haven't really figured it out. It's just really exciting opportunity. I love problem solving. My job is to make my providers, my physicians and APPs jobs as easy as possible with tools and support. And so we're investing as much as we can in making their lives easier and making it as easy as possible to run a clinic effectively in a small town.
It's your turn.
Thanks, Dan. And, Tim's comments, Tim was one of the first panelists I heard this morning. And, it does bring to light the fact that good work is happening. I think for a long time, value-based care and value-based solutions were happening in a trickle-down methodology from the largest metropolitan areas, and maybe they could trickle down to medium communities. Very little got to the smallest communities in America. The communities that may need it the most. For myself, my personal motivations have been the fact I'm from a small town. I'm from a small town, grew up, and I think about the mother rule. I spoke to Dr. Goodrich after her comments earlier, sharing about her mother's care, right, in the lack of navigation, the extra care that was needed, and the frustrations of, despite having a great doc, the frustrations of getting that for her mother. And so I've always used in practice kind of the mother rule. What kind of care would I want my mother and father to have? And I know that I was fortunate to be in a large independent medical group of approximately 25 physicians. We were able, in challenging primary care reimbursement, which we've discussed at length today, to stay afloat because of size and leverage. Well, you don't have enough docs to have a 25 physician group in small town America. So how do we support those smaller practices, but let them stay independent if they so choose? And that's really what drew me to the innovation of Main Street when I heard the model. I had been leading value-based relationships for approximately a decade, but again, those solutions often weren't a good fit for smaller towns and smaller practices. When I heard the innovation with Main Street, able to support the smallest of physician practices in the smallest of towns, but was so innovative and logical that it worked upstream as well, with real help when we talk about the investments, you mentioned investments and innovations, I knew I didn't have enough help in primary care. 3 of the top 5 burnout specialties by the AMA study last year are primary care specialties, because they don't have enough help, but they also can't afford help, right? They're barely keeping their head above water. So our mission of investing in primary care by supplying health navigators that we pay for in small towns across America and making value-based revenue reliable as opposed to a very complex puzzle that requires a lot of investment by the practice is really what drew me to the point I am now.
And neither you nor Tim mentioned this, but when you're working in these accountable care models, you get more of the financial information, and financial information is evidence, just like clinical information is. How are you using that information to help inform the care you're providing the patients?
Yeah, no, I mean, the data available, and again, I think this is something we take for granted now, but this is inconceivable 20 years ago when some of these reforms hadn't been even put into law yet, of like access to claims data, visibility into where patients are going, where they're seeking care, not just with you, but with others in the community, others when they travel. That gives you visibility into their risk, their relative likelihood of admitting. If they're not filling a script, then you can know that within a matter of a couple of days, sometimes less, depending on how you're setting it up. So there's the claims data, layering it together with other sources of information, phone call data, like what they're calling us about, and then, of course, clinical data in the EMR allows you to really get a much more rich and holistic picture of a patient's experience and needs than was ever possible, certainly 20 years ago, but even 5 years ago, the ecosystem has really matured a lot. So that allows you to be intelligent about where you're putting resources and who needs to be coming in every month rather than just when they escalate, who needs a special attention from care navigators and nurses and other members of the care team to solve problems that may be escalating. How do you track down a patient within a day or two after they're discharged from the hospital rather than waiting for them to show up again or waiting for the payer to feed you the data? So tremendously important part of the work that we do is work that our data engineering and product teams do to push information to our clinical teams for direct management of patient needs.
And Jim, I'm sure when you start working with a practice and you suddenly start showing them this data, it's a little bit of a culture shock. So how do you work with them to understand the pearls and nuggets that can come in that data?
Well, I think as a physician, what I really wanted to know is which of my patients do I need to be worried about, right? I think one of the things that I've had the pleasure of telling PCPs, which we serve primary care practices across the spectrum of value-based care naive who didn't realize the money was out there, to sophisticated practices who are like, yeah, we've been investing, but the money hasn't necessarily been reliable to help us fund the clinic. And we're overwhelmed with data and lists coming in from everywhere, from every plan, and we can't keep up with it. So again, our model is fairly simple, and it's why I joined Main Street. Basically, all the data the clinician needs to know is fed through our navigator. I tell them, we're not giving you a portal, there's a person. When I go live with clinics, they're like, well, how do we log in? I'm like, you don't log in. Susie will be here tomorrow, and she's going to give you all the information you need, and the discharge data and the preventive health data and who hasn't been in the practice, that's all on our shoulders, her shoulders. But she's a member of your team, and she's a community health worker. I met with one of our navigators yesterday in Northwest Alabama, who's a seasoned navigator, but she was new to this practice. And the first med adherence, Tim mentioned med adherence, one of the first med adherence calls she made yesterday, she was calling the patient because she hadn't picked up her medication, and the patient told her lights were about to be cut off. So she went to work getting the light bill paid by the local community, because if our seniors, if they can't pay their light bill, they're not going to pick up their blood pressure medicines. So it's really the whole care of the person, right, and the real help.
Figuring out what the most important thing is, and a lot of times that doesn't involve the prescription pad. So how do we address the workforce shortage going on in rural areas? I mean, I guess we can start with Carrie from sort of the policy standpoint, but then would like to know the people working in these practices, how do we address this going forward?
Yeah, I mean, when I think about workforce, you think about training, distribution, and retention as kind of your three big buckets, right? So kind of going back to some of the earlier comments I made about training, we've learned over time that place really matters when we're talking about physician training. And there was a study that came out a couple years ago that had some great data that showed individuals who do their residency training or some level of training within a rural setting are 5 times more likely to practice there. If you're from a rural area, even if you don't get that residency done there, you're still 4 and change times more likely to practice there. And even later in the careers, that continues. So, we really need to think about how we are investing and supporting those training opportunities. And we all know kind of the pipeline all the way up to residency and how important all of that is. But I think that's, so often when I talk to folks in the field, the capacity to do that kind of training is so challenging when you are a small practice, when you're already strapped in terms of your workforce, having to choose between providing clinical care and taking on a student is a really challenging thing. And so thinking about how we invest in programs to do that is really important, and to how to lift up those successes. And I think another area I would hit on that Sonya started to talk about is just how do we wrap around the experience of individuals who are trying to set up practices and live in rural areas. So often, we don't think about the investment of what it takes to run a small business as a physician, right? And so where are there opportunities where we can offer tax credits or incentives to have clinical practice, whether that's, if you're practicing in a HIPSA, or if you're serving as a preceptor, or if you are kind of creating a new capacity in a rural community, how do we kind of reward that? And then again, wrapping around things like housing shortages and childcare shortages and so much that's needed in our rural communities. Rural communities on the whole are struggling, and so we need to think about kind of the economic development that goes not only with healthcare, and the role healthcare plays in that, but also in the broader community, so people can continue to live healthy lives in those settings.
Sonya, what do you think? Again, Eastern North Carolina and the Eastern Shore you've got to be a special person to want to live in those areas, right?
Absolutely. Some of it is stopping those little cuts. And so some of the cuts come from things like 24-hour call, and many clinicians not wanting to do 24-hour call and not having the hospitalist model as an option. And so it's having different options for that. It's making sure that when you are on call that there are companies that are, through standing orders and through the clinical teams that they employ, able to take as many things off of what has to actually go to the physician as possible. It's little things like having and being willing and having a relationship to have a 3-month hotel stay until you can actually find housing that you want to live in or that you can afford. It's really increasing the workforce by looking at those 50-plus age providers who've been running a business for a long time and they still want to practice medicine, but they need a little bit of a break, and merging with them. There's a lot of those kind of acquisition type things that are happening in both of the areas. It's also looking back at the people who did come up from there and did become physicians and maybe have lived elsewhere, and they have their spouse and their children have gotten through school, and saying, how about coming back home? It's time to, now that parents are getting a little bit older, or you're at a part in life where you maybe are a little bit more interested in being around your family. A lot of those kind of outreaches and beginning to track folks that got away and convincing them to come on back home.
Yeah, but it's... you're talking about spouses. So I was practicing in a rural area when I got married, and my wife, the biggest shock to her was going to the grocery store, going anywhere. Everybody in town knew who she was, and they knew that she was my wife, and that was something that really got pretty difficult for her. She wasn't used to it. She had grown up in a larger area, and so that was something that we had to sort of have our boundaries as to who could show up at the house unannounced and who couldn't show up at the house unannounced.
A little bit of those culture shifts. I know the folks at Chop Tank even talked about residents like to see their physicians in the grocery store. They like to see them walking around, and that kind of People magazine, they're just like us, seeing them do those things just like you, and they appreciate those connections.
Tim, how are you all handling workforce?
No, I think that it's a really good point Sonya made, and I think of this as like related to expectations from the physician workforce for a more modern practice ownership and management experience. And so we have a few practices where we acquired the practice, and thinking of like Dr. McCormick, who works with us in Tryon, North Carolina, absolute pillar of the community. Everybody knows her. It's daunting for another physician to come in and have to be Dr. McCormick, right? And so we've partnered with her and brought her more team members. We've brought her physician's assistant. We've brought more team members to support the panel. We're able to recruit someone who, it's a very, a lot of these places are very nice places to live, able to bring someone in who wants to be there, but is not going to have that same level that Dr. McCormick had to, going through the transition of getting her own IT and doing HR forever and contracting, right? And all those things have gotten more complicated. That's true across healthcare, but it's especially acute when you have like a 3,000, 3,500 patient panel to manage, and you're the only show in town, right? So I think what we're able to do is bring an experience where the physician can still practice and see the patients, have full accountability and that full relationship practice top of license with a really well-supported team, the best technology, really good economic arrangements for them and their families long term, but be able to do it in a way that's more in accordance with the way they want to practice today versus the way it was 30 years ago.
And Jim?
Well, I'll say, Tim, I love that support you're speaking about for new clinicians coming into communities that Hopscotch is providing. That's wonderful. And I love Carrie and Sonya, y'all's comments about both the challenges and also the opportunities. The fact is, like, being from a small town, Dan, we know that, physicians are still thought of as, kind of the pillars in the community. They're very respected, especially primary care physicians. It's such an honor to be a primary care physician because it's truly that one specialty where people consider you their doctor, right? And it's almost a possession of you as their doctor in the grocery store, right? At Main Street, we don't acquire practices or employ physicians, but I think what we do that we're hoping helps is value-based revenue. If we can supply them predictable, reliable, a simpler solution to value-based revenue that they can count on, hopefully they can use that to help fund the next clinician that joins them. Maybe a physician, maybe a nurse practitioner. That's okay, but it's primary care. And I think the other thing is trying to make their life better with health navigators to take some of those administrative burdens and non-clinical needs of patients off their shoulders to make their life better. Perhaps they can get their head above water and actually be able to think about how they survive and grow in primary care.
Great points. Now we're going to give Carrie the tough question. So, proposed budget cuts significantly impact rural health care programs and training. What are the risks there, and what can be done to mitigate those risks?
Yeah, well, we can hope for a miracle that the detailed president's budget comes out with lots of changes, but just as a reminder for folks, we saw a leaked version, an early version of the FY26 president's budget, and it did not look good for rural health or for some of the workforce training programs that we have within HHS. I think it's really important, just as a quick synopsis of that. And again, I want to reiterate that while we've seen a skinny version of the high-level numbers that's been officially released, we still don't know the weeds of what's below that. But based on what we saw in the leaked version, core rural healthcare programs that help to support the infrastructure in rural areas, like the state offices of rural health, the Medicare flexibility program that supports small rural hospitals and EMS, the Rural Residency Planning and Development Program, which is a program that has been immensely successful. It's a pilot out of the Federal Office of Rural Health Policy that's been operating since 2019. And in that time period, it has helped to stand up 54 accredited residency programs in rural areas and create over 650 new residency slots in rural, and about 2/3 of those are full. So we are really seeing progress with that program, and it has been zeroed out. So those are really kind of targeted rural efforts that we need to bring back. And then in the Bureau of Health Workforce, or what is formerly currently in process of the Bureau of Health Workforce, we saw a bunch of some of the core training programs that target rural or underserved communities, like the AHEC program, faculty loan and faculty support programs, geriatric programs, the list goes on and on. So in terms of what we need to do, we need to all collectively raise our voice and work with your members of Congress. The way the president's budget works every year is that, the president puts this out as his or her priorities for what they want to accomplish in the administration, and then Congress comes back and kind kind of debates that and comes up with their own proposal. This being the first year of this term, I think there's a lot of interest in trying to support the president's budget as much as the Republicans in Congress can, but they need to hear from us collectively about what impact this would have on our communities.
We'll go just sort of a quick round with a magic wand question. So if I could hand you a magic wand and you could get payers, the policymakers, or the providers to make one change in rural health care, what would it be? And we'll go the reverse order this time. Jim, what's...
I think we've talked about kind of the understanding that reimbursements for primary care, especially independent primary care, is a very challenging proposition. And primary care now, to stay independent, those independent practices and small community hospital practices and large practices depend on value-based income to stay viable. But it's a very complicated system. It's ever-changing. It's incredibly hard to manage, especially when it's not just one value-based system, it's multiple. So if the payers and Medicare and the commercial payers could get on the same page and make that a simpler program so that it was not such a maze to navigate, so that clinicians could focus more on the patient care and improving patient outcomes, that would be my one wish.
That's great. Tim?
I have a very long list, actually, but I'm going to attempt to give one, like making a wish for more wishes type of thing, where if we could have I think I've seen some states do regional planning really well, and it's hard to do because they don't have enough power, and you end up needing things from Medicare, and you need things from different parts of the government. If we had a way to create empowered, funded regional planning collaboratives that could sort of intelligently engineer the relationships between urban centers and the rural needs, I think you can get a lot of work done. And I think that some states like Pennsylvania, state of Washington, Vermont, I think that they've made some progress doing that, and I think we should turbocharge that and do it widespread.
Sounds like a great idea. Sonya?
I think for me it would be force them to follow the rules and just do what's right. There's so often things that are required to be reimbursed or paid aren't. You have to fight to get the actual claims paid, or they're greatly delayed. So it would really be about the structure of the process of putting in a claim and actually having it paid and getting that payment to you on a timely basis. That could go a long way for the cash flow that's necessary to keep the rural health care going and growth to happen.
I am going to go political because that's my job, but I think as much as I would like to be forward thinking about what we could do to fix rural, I am definitely in a defensive crouch right now. The decisions that are going to be made over the next several months between reconciliation and the president and the appropriations for FY26 really have the potential to devastate rural communities. And you mentioned early on kind of, we're so reliant in our rural communities on public payers, so Medicaid, the marketplace, Medicare, and as we're talking about the potential policy changes that are being discussed in reconciliation, especially around Medicaid, that is going to have not only significant consequences for the individuals that are losing or changing coverage and benefits, but the people who are caring for them in their rural communities are going to have to take on debt. They're going to have to turn people away. It'll be a rippling effect. So I would like policymakers to really, as they're looking at these things, really understand the impact that will have on access to care in their rural communities and make sure that that's the decision that they want to support.
Thank you. Great thought. Many view rural and urban healthcare as separate spheres, each with its own unique challenges. In some ways, I think this rural healthcare we're talking about might be the canary in the coal mine. If the rural areas struggle, the other areas are going to have a difficult time. So innovations emerging here have the potential to transcend geography, shaping solutions that benefit all the populations.
What are your thoughts on innovations in primary care, independent and rural primary care practices? You've heard ours, now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.